I've had an opportunity to review your medical records and examine you.
In centers where the procedure is available, younger men with localized, lower-risk prostate cancers are more often opting for treatment with brachytherapy rather than surgery.
The first important step is meeting with the radiation oncologist to determine the suitability of the patient for the procedure. One of the advantages of this procedure is that once you wake up from the anesthetic, and if you're able to urinate properly and have not had any problems with bleeding or unusual side effects from the anesthetic, we send you home. The next step is to perform a transrectal ultrasound procedure where we obtain images of the prostate gland. Mr. Smith, I'm going to begin the procedure now. This is the ultrasound probe, and I'll be inserting this into your rectum. And there's a little device on the end of the probe that will give me an ultrasound image of your prostate gland. It's going to be a little bit uncomfortable here. Now I'm moving the probe in and out to check the position of your prostate. These images are fed into our planning computers where the radiation oncologists and physicists work to devise a plan in terms of establishing the proper position of the radioactive seeds that will be implanted in the prostate. We need to avoid certain critical structures or organs around the prostate gland. Some of the structures to consider are 1, the bladder and the urethra, number 2, the rectum, and also the neurovascular bundle, which is responsible for erectile function in men. The patient is taken to the operating room. He's put under an anesthetic, which is usually a general or spinal anesthetic, and for the next hour to hour and a half, the radiation oncologist will go through the process of implanting those radioactive seeds into the prostate gland. So I'm going to be inserting the first needle. This needle is hollow and it contains the radioactive pellets which are stored at the tip of the needle. The needle is inserted through the perineum into the prostate gland. You can see the little bright spot there. That's the tip of the needle. We visualize the insertion through the use of the transrectal ultrasound. Once the needle's in place, in the prostate gland, we remove the needle, but we leave behind the seeds, thereby implanting the seeds into the prostate gland. They will emit radiation for a period of time, and then they will become non-radioactive.
4 weeks later, a CT scan of the prostate is done and analyzed to ensure the dose and position of the seeds are at their most effective without damaging any more of the surrounding tissues than necessary.
Based on a wealth of experience from several centers across the world using both treatments, we strongly believe that radical prostatectomy and prostate brachytherapy provide equivalent cure rates for the properly selected patients with prostate cancer.
For men who are not good candidates for surgery, or those whose cancer has spread outside the prostate, external beam radiation may be the best choice, often in combination with hormone therapy.
In this particular patient, he has locally advanced prostate cancer. It's outside the prostate, T3. Also, it's a Gleason 8. This is a bird that is likely to have spread and set up nests somewhere else in the body. So we need to attack this in a combined modality treatment, treating with hormones to treat the whole body, as well as some sort of local treatment, and we would recommend radiation so we can take in not just the prostate, but a 2-centimeter margin around the gland.
External beam planning involves putting marks on the skin, reference points that refer to where the prostate is deep inside you. To achieve that, what we normally do is put you on a special bed and outline the prostate with dye, and then do a spiral CT scan, which allows us to capture pictures of the internal anatomy in 3 dimensions on a computer screen.
And this is shows the outside skin contours of the patient. And so here on this side you can see the patient's left leg, and this is the right leg, and we can actually have a look on the inside and see how we've actually delineated the patient's target prostate area that we're going to treat.
Then by visualizing the prostate, the bladder, the rectum, we can focus the radiation and minimize side effects of treatment. We use multi-leaf collimation so that as the machines go round you, the shielding changes so that it maximizes the protection of the normal tissue, the bladder and bowel, so minimizes side effects of radiation. The new kid on the block is intensity modulated radiation therapy, IMRT, and that's becoming more and more available, which will even further allow us to focus the radiation on the prostate and protect normal tissue.
Hormones may be given to shrink the cancer and prostate before local treatment or in conjunction with radiation to improve the chance of a cure. These adjuvant therapies are now the standard first-line treatment for men with high-risk cancers.
High-risk treatment involves assuming that the cancer has spread. And then what we do is treat with hormone therapy to remove the male hormone from the system. That tricks the cancer to thinking it's in a female body. That triggers a suicide gene, and that the PSA goes right down, and you can destroy up to 90% of the cancer. Once the cancer is in remission with a PSA less than 0.1, then by radiating, firstly, you're treating a smaller tumor, which has shrunk right down, so that you can get away with treating with smaller fields, so side effects are less. And also it's like playing a game of golf, except because you're starting 90% of the way up the fairway before you hit the ball, each fraction of radiation kills 50% of cancer cells. If you've already killed 90% with the hormone treatment, you're ahead of the game.
The other advantage of using adjuvant hormone therapy is that these days we have better drugs which have less serious side effects, while at the same time being able to shrink the prostate gland or the cancer quite effectively.
There's some evidence that by putting the cancer in remission before radiation, you may be creating a systemic effect so that the cancer seems to stay in remission for much longer than you would expect. A lot of our research is looking at this, and we think that we're actually creating an immune response and triggering your normal immune system to recognize the cancer, which is why we have these very good results.
Another treatment that's been around for some time but which is now being studied and offered in a couple of Canadian centres is cryotherapy. This involves placing probes through the perineum and into the prostate, and then freezing the gland into a block of ice, allowing it to thaw, and freezing it again. The ice damages the cells and the blood vessels that feed the tumor. Over a week to 10 days, the gland dies, and the body absorbs the dead tissue over time.
The patients that I think are most suited for cryosurgery as a first-line treatment are those men with localized disease who are somewhat older, or who are not fit for surgery, or do not want to have surgery, or do not want to have external beam radiation or brachytherapy. A very good role for cryosurgery is in the treatment of patients who have a local recurrence of prostate cancer within their prostate following radiation treatment. Cryosurgery in such patients can yield a long-term cure rate in the region of 50%. The patients most suited for this treatment are those who have a Gleason score of 8 or lower, a PSA lower than 10, and a PSA doubling time of greater than 1 year. In such patients, this is a very effective salvage treatment.
Some of the treatments now considered experimental will eventually become standard as clinicians and researchers collect longer-term results.